Thank you for joining us and welcome to today's webinar, Documentation Guidelines for Coding, Is My E&M Supported with OMT? Our speaker today is Susan Carbone with the Coding Network. Susan is an expert on this topic and has extensive experience with audits and provider education. So with that, I will turn it over to Susan.
Thank you and welcome everyone. And let's talk about the course objectives. So the objective here today is to ensure that your E&M level is supported when billed and it's appropriate to bill with your OMT procedure. So I want to make sure and go over what you need to document in your note to support that E&M, including the chief complaint, reason for visit, and then the key components of history, exam, and medical decision making. I like to cite some references that I've used, one of which is National Government Services, and that's one of the Medicare contractors that would be a good source of information, and there's a link to that. Also, there's what they call a local coverage determination for OMT, and this is a very good reference as well. And I do have some information within this presentation that I took from here. Just a reminder that the ICD-10 official guidelines for 2020 are out. They came out October 1st, so there's a link for those. And then, of course, I did review the American Osteopathic Association's Guide to Coding. So some information was obtained from there as well. But let's start out talking about that local coverage determination that was put out by National Government Services, because they specifically do state, as most of the insurance contractors that I've looked at do state, that your OMT procedures specifically encompass only the procedure itself, and that those E&M services are covered as a separate and distinct service when medically necessary and appropriately documented. So we will definitely talk about this piece where what do you need to do to appropriately document your E&M level. And of course, then what you would do is you would assign your E&M needs a modifier 25, which states, yes, this E&M is separate and distinct from that OMT procedure. But one of the distinctions that National Government Service makes, they have these two sentences here that are kind of interesting. One of them states, OMT utilized at a follow-up visit is not the same as follow-up OMT. So it's like, okay, what does that mean exactly? A follow-up visit for OMT is considered a predetermined service and would not support another E&M for the same problem. So if your chief complaint or reason for visit, which I did see in some of the notes, states patients in for a follow-up visit for OMT, the insurance contractors, if they're reviewing your note, are going to zero in on that as this patient only came in for the procedure and the E&M is not going to be supported. So it's very important when you document the reason for the visit to make sure that it's clear whether or not they're just going to have the procedure or you're doing some sort of an assessment or evaluation. Because their other sentence says a follow-up visit where OMT is utilized is not necessarily predetermined, unless the preceding progress note denoted it to be an OMT visit. So they may look at your previous progress note as well to see what was the intent from the previous visit when the patient comes back. So again, the insurance contractors do say those E&M services may be separately reported if the patient's condition requires what they call a significant separately identifiable E&M service above and beyond the usual pre- and post-service work associated with the treatment. And on the next slide, we're going to take a look at, well, what is exactly pre- and post-service work look like, so that you would know, well, I need to additionally document those key components of an E&M service. Keep in mind, different diagnoses should not be required. So if an E&M service is being reported on the same day as the OMT, the documentation should clearly distinguish the services that constitute those key components. You want to make sure that you have a documented history, a physical exam, and an assessment and plan. And just as a little background information on what's going on, why is this such a big deal all of a sudden? Why is it even a problem? The trend in the insurance industry right now is to initially deny the E&M when billed with an office procedure. And it's not just your specialty. This goes across all specialty groups. So all specialties are really dealing with this right now. A lot of insurance contractors have put edits into their system that will automatically deny the E&M service when billed with the same day office procedure. So a lot of times what happens is this requires actually a two-step process to get the E&M paid, because a denial will come back and the billing department is going to have to work that claim, so to speak, and take an additional step of sending in your documentation that shows them, yes, this does support the separate E&M service. So we want to make sure that your separate E&M service is appropriately documented. So let's look at that. What is the pre and post service work where your E&M is going to have to go what they call above and beyond this information? Well, the pre and post service work simply is just the work for the OMT, which includes determining which techniques you're going to do, in what order the affected body regions will be treated, and then just some of the pre-service work of explaining it to the patient. And the post-service work is the post-care instructions that you're giving to the patient. So typically, if you're documenting additionally a separate history, you typically will have your exam and an assessment and plan to support the E&M. That certainly would go over and above this kind of information. Now, when wouldn't you report that additional E&M service? Well, if the patient is coming in for scheduled, predefined number of follow-up OMT treatments for an episode of care, for example, you would not want to report a separate E&M service on those dates, unless there was a new condition or a change in the patient's symptoms and you would have to document that. Or another scenario could be that the patient comes in, they have their E&M service, but they can't stay for the OMT treatment for whatever reason, and they come back the next day. That next day, you wouldn't go ahead and bill another E&M service. You would just bill the OMT treatment. But the important piece of information is in the beginning of your note, clarify the intent of the visit. And also, what did the preceding progress note indicate? So again, that follow-up visit for OMT, if that's stated in the beginning of the note, the insurance contractor is going to say, well, that's a predetermined service, and they're not going to want to pay that E&M service. Whereas if the follow-up visit was for evaluating or reevaluating the patient's conditions, and then the decision's made to perform an additional OMT, that's not predetermined because that evaluation was required, and then the decision was made at that visit to go ahead and do the treatment. But remember, if it's not clear one way or the other, the E&M will not be supported. So let's just take a look at one of the notes that's problematic. Okay, so in this example, was this part of multiple treatments planned, or is there a reassessment going on? Well, again, right in the beginning of the note where it says the patient presents to the clinic for OMT, I'm afraid most insurance contractors are going to look at that one sentence and not go much further in making their decision that they don't think a separate E&M is going to be supported. So make sure the reason for the visit, the chief complaint, is documented somewhere within that history section, and it clarifies the intent of the visit. This is going to establish the medical necessity for the services. So it could be a separate chief complaint, which I did see there is a room for that in the very beginning of the notes of the templates that I've looked at. Or it can be indicated within the history of present illness as well. So just some examples stating the purpose of the E&M service, that was provided was to evaluate a specific complaint or problem. So it's just establishing that information in the beginning of the note is really important. Or describe how and when the patient's condition had substantially changed, or that the reassessment of the problem or the treatment plan is necessary, and that the patient's visit was not scheduled for the explicit purpose of just performing that procedure. And just an example of the history, an established patient returns to the office for reevaluation, and again, stating that would really help support that. And then the continued low back pain, previously relieved with OMT, and has become or still is painful again. So again, you know, the key components of the history of present illness elements, the review of systems, for example, additional symptoms including tingling noted, some radiation to the legs, feels stiff and achy, has tried to do his normal daily activities and having trouble with it, taking aspirin with minimal relief. So somehow indicating that that reevaluation is required to determine the appropriate treatment. And in your templates, I did notice you have a lot of HPI typically documented. So just as long as it's established early on in the note that they're here for a reevaluation versus just the OMT treatment. Again, this note clarifying the intent, and there's space right here to do it. So there's extra space in this template, it looks like, where you could certainly indicate in at least another sentence the reevaluation, the symptoms, and of course there's plenty of history of present illness and review of systems can be taken from this as well. Okay, so this may state this is history of present illness information, but you can take review of systems from here. For example, under associated signs and symptoms, you could use that for review of systems as well instead of HPI. There's plenty of HPI here. And remember, once you get to at least 4 elements, you've satisfied the highest criteria for the HPI elements. One thing I would make note of in your HPI is to make sure that this is unique to this visit. I don't know if anyone is copying forward, copying, pasted information from previous visits, etc. Make sure that there is not conflicting information from what you say here is the reason for the visit, and then any information that is within the HPI and review of systems. So again, just going over the history piece, making sure that all your history elements are documented. The chief complaint or reason for visit. Document your history of present illness elements as we just saw in the previous slide. Review of systems, and then past family or social history, whatever is pertinent. Just a brief overview of, remember there's 8 HPI elements. Again, once you've gotten to at least 4 elements, you have the most extensive HPI. You don't need to document all 8, but whatever's pertinent to that visit. Could be 4, it could be 8. And then these slides, again, just describe what the different HPI elements are defined as. And I think that the documentation for this seems to be going very well in the notes. From severity, duration, the timing, the context, the modifying factors, and the associated signs and symptoms. And then your review of systems, there's 14 possible review of systems. So you don't have to document all 14. You need at least 10 documented for a new patient visit if it's going to be a level 4 or 5. So just keep that in mind. But with your follow-up visits, typically at least two will at least get you to what they call a detailed history. That's one step toward a 99214, but it would also satisfy a 99213 as well. But again, for new patient visits, levels 4 and 5, or if it's a consult, level 4 or 5, a complete review of systems is required. That means at least 10 systems must be reviewed. And those systems with positive or pertinent negative responses must be individually documented. Do you need to individually document all of them? If the rest are negative, you don't need to. Actually, the documentation guidelines state that once you've documented the pertinent positives or negatives, whether you have a separate entry for that in your note or it's within the HPI section, either or is okay. You can state all other systems have been reviewed and are negative. That is permissible if in fact you're really reviewing at least 10, but you're not going to individually document all the negative ones. And some ways that you can state that, again, once you've documented some pertinent positives and negatives, you could state all of the systems have been reviewed in negative or the remainder. You could state review of systems was obtained and except as listed in the HPI, all other systems are negative. So there's different ways to document that. Typically for your follow-up visits, you're not going to need a complete review of systems. The only time you would possibly need that complete review of 10 or more was if you were billing out a 99215 and you needed to count the history section. What you don't want to do with the review of systems is just make a blanket statement that they're all negative or they're all unremarkable or they're non-contributory and you haven't really documented any pertinent positives or negatives at all. And then the past history is pretty self-explanatory. These are just examples of past history that you could document. Typically for your follow-up visits, you don't need more than one past history item. The same thing with family history. There's one thing that we've noticed from insurance contractors is that some of them, not all of them, but some of them don't seem to like the statement family history non-contributory or there's been no change. I think where they're coming from with this family history non-contributory is that there's some EMRs where that's almost a default statement that comes into the note or can easily be clicked into the note. And I think the insurance contractors aren't sure. Maybe you're really not asking anything at all. It's just clicked into the note. What we recommend is that if you need to document a family history, you would state that you reviewed it. And if in fact it is non-contributory, then you can go ahead and state that. The only time that you need the past, the family, and the social history, all three documented, again, would be your new patient visits, levels 4 and 5, or your consults, levels 4 and 5. And then social history, self-explanatory examples. Now let's talk about the next key component, and that is your exam. And I didn't see really any problems with the exam portion when I looked at it. I looked at a sampling of notes, didn't see any issues with this. Of course, you want to make sure that your physical exam indicates the presence of somatic dysfunction of one or more regions. That's got to be appropriately documented in the record. It should describe the pathology in the areas skeletal, arthroidal, myofascial, those sort of structures. And the diagnosis of somatic dysfunction is made by determining one or more findings described by the acronym TART. So the physician should document any change in pain or function along with the presence of somatic dysfunction. So it may include, but is not limited to, just some examples here. And let's look at an exam. This is an example of a note that I took from one of the audits. And this is a well-documented exam. And certainly the musculoskeletal system certainly has the information that's needed. Somatic dysfunction in the different regions. But this also points out that it's got other systems documented as well. It does help to support if it's pertinent to that patient or that visit. It does help to support the complexity of the E&M service. But again, you know, you document the exam according to what you feel in your clinical judgment needs to be documented. Making sure in particular that, you know, the somatic dysfunction is supported. So let's just go over some of the key components of the exam. There's 4 types, anything from a very limited or problem-focused, that would be a very low-level, probably, exam, to expanded problem-focused, a little bit more extensive, but it's just maybe 2 or more body areas or organ systems that there's not a lot of detail within the exam portion. It seems to me that most of your exams that I've looked at are at least detailed. Okay, and we just saw that in the previous example where the musculoskeletal system was well detailed, and then there were other symptomatic or related body areas or organ systems that were also documented with some detail in them. Keep in mind that the comprehensive exam, which actually requires 8 organ systems to be documented, you need that for your new patient level 4 and 5, or if it's consult level 4 and 5. Interestingly, the 1995 exam guidelines, which are the ones that you're typically following, they've made this distinction between body areas and organ systems. So they've defined what they feel is a body area, and then they've defined organ systems. And organ systems is anything from constitutional, that could be your vital signs documented, or simply stating patient in no apparent distress. Keep in mind organ systems, eyes is separate from ENT. But the question is, why does it matter? The only time it matters is for the comprehensive exam where you have to have 8 or more organ systems. If any of the 8 were really just body areas that were defined in that previous slide, you wouldn't get credit for the comprehensive. And again, the comprehensive exam is what you need for your higher level new patient visits, levels 4 and 5. Other than that, you don't need to worry about that distinction at all. Now, we come to the difference between an expanded problem-focused exam and a detailed exam. And of course, the definitions are very similar. And so we typically like to look at least one of the Medicare contractors in the area to see, well, maybe they further define this because these definitions are pretty vague. So we did find, I believe this comes from National Government Services, you know, define the detailed exam. Well, it's 2 to 7 body areas or systems. It could be either body areas or systems, but expanded documentation of the areas or systems are examined requires more than just checklists. Needs to have normal and abnormal findings expanded upon. So the recommendation is at least 2 or more items for 2 or more body areas or organ systems is detailed. That's pretty easy to get. Here we have musculoskeletal. You know you're going to have at least detailed in your musculoskeletal system. Typically, most of the notes are going to have at least that. And then just one other system really is required. And again, some detail. A couple of items. This one has 3 what we would call items. Areas of focus on the exam. So this would be a detailed exam. Again, most of your notes that I looked at easily supported this. And then, of course, for your comprehensive exam, the 8 organ systems are listed here. So general would be constitutional. We have eyes separate. There's cardio, GI, skin, psych, neuro, and musculoskeletal. If you're following what we call the 1997 guidelines, and these came out two years later when the specialty group said, we don't always examine all the different various organ systems. We would like you to zero in on our specialty in particular. So there is one for the musculoskeletal exam. If in fact maybe your templates are more built on this type of template than on the 95 guidelines, either or, an either or system can be used. Either or system is going to be looked at if you were audited. Both would be compared and give you credit for, you know, the one that gives you the most credit, basically. But just keep in mind that these bulleted items now have to be documented. So expanded problem focused, at least there's a better distinction between detailed and expanded problem focused, where they tell you expanded is at least 6 elements and detailed is at least 12. And when you get to comprehensive, you've pretty much got to document everything. You really need a template for this. And this is what it looks like. And then there's all these bulleted items that have to be really counted, I guess, toward whether it's detailed, comprehensive, etc. So the difference between the two, I mean, the 95 guidelines are a little bit easier to meet for the exam. And we saw that example. The 97 guidelines, you have to count the number of elements or bullets. But if you have templates set up for this, it's not that difficult as long as you have a template or a macro of some sort. So just making sure, again, on the exam, any specific abnormal and relevant negative findings are documented. Anything abnormal is expanded upon. The exam is real time, so you can't indicate no change from the previous encounter. And then let's talk about the third component for an E&M service, and that's your medical decision making. And this is your assessment and plan. So make sure that there is an assessment and plan documented. Without that, you're not going to capture an E&M at all. So you're going to want to list the number of diagnosis and management options. Again, you know, what conditions are you following and what are you doing about them? Then there is also this portion where any tests that you might have ordered or reviewed can be captured. And then it's all compared to this table of risk, they call it, which is really just a bunch of examples that, for example, an auditor would try to map your assessment and plan to examples on this table, and we'll take a look at it. It's not always a good one-to-one match, of course, so there's a lot of subjectivity in it. But the important thing here is make sure you document an assessment and plan. It supports the medical decision-making component of the E&M service. So the physician can support their diagnosis of somatic dysfunction in their decision to perform the OMT here. And this is an example note, and here we do have a good assessment and plan. So the patient's been having significant difficulty with lower thoracic and low back pain and spasms, and moving stiffness in the neck and upper back are also documented. OMT is provided to reduce pain and spasms and improve function with good results. So this is good supporting documentation of, okay, I've done the evaluation, this is my assessment, and now I'm going to plan to do that OMT procedure. And then the list of DIAGs here, the only issue that I have with this is that it's kind of hard to tell because all of these diagnosis codes are listed here. Is this all related to this assessment? I would recommend list the diagnosis codes that are pertinent to the assessment and plan and the evaluation. because this is a little bit confusing. It's hard to tell if all of this is supposed to be related to this, and if it is, then all these ICD-10 codes, you know, have to be selected. So it's extra work as well. You don't want to select and link ICD-10 codes that don't have anything to do with the current evaluation of that patient. So just keep in mind there's 4 types of medical decision making, and to qualify for a given type, the criteria for 2 out of 3 tables must be met or exceeded. I'm going to go over this briefly. I know it's not something that physicians are really thinking about when they see their patient. I'd just like to go over it to give you an idea of how your notes are looked at, so that you have an idea of maybe there's some documentation tips that you can take from this that will help support the complexity of your E&M service, or that certainly the E&M service is supported, period. So remember that there's 3 medical decision-making tables. 2 of the highest scoring ones, so to speak, are counted, and the 3rd one can just be dropped and not counted at all. So the first one is the number of diagnosis and management options, and basically, again, that's looking at your assessment and plan. How many conditions are you evaluating? And it's a point system, but these points are not based on the number of problems. They're based on the severity or the stability or the non-resolving. So it's really the status that these numbers kind of go along with, the status of those conditions. The second table is the amount and complexity of data. Again, it's a scoring system of points, 1, 2, 3, and 4. And then the third table, which is the overall table of risk that we'll take a look at, is again, it's just examples. But just as an example, 2 points typically leads to low complexity. So if 2 of the tables supported 2 points, that typically leads to low complexity. On a follow-up visit, that's your 99213. 3 points typically leads to moderate complexity. On a follow-up visit, that's a 99214. And then once you get to 4 or more points, you can get into high complexity. But again, 2 out of the 3 tables would have to meet or support high complexity. That would be a 99215. So let's take a look at the first table. Again, it's just the assessment and plan. And this is what the table looks like. So, but I want to go over a couple of these columns. First of all, if it's an established problem or problems to you, whether they're stable or they're not stable is really important to document, because that helps to support the complexity, because as you know, the point system gets higher if the problem is not typically considered stable or improving. So if it's not resolving, if it's worsening, if it's failing to progress, however you want to word it, still symptomatic, that'll help support a little bit more complexity. And this is cumulative problems. So if you had 2 or 3 stable problems, you would get 3 points, not just 1. Whereas if you have the new problem, no additional workup automatically gets 3 points. Okay, remember 3 points is 1 step toward moderate complexity. A new problem where you need to do additional workup because maybe you're not quite sure what that definitive diagnosis is yet, that gives you at least 4 points on this table. So again, just making sure that the status, particularly of the established follow-up visits, documenting the status is really important. Now, for new problems with additional workup, what would you consider additional workup? Any additional tests, of course, but maybe a request for a consult. Maybe you state that you need to get in records from another facility. You need to take a look at more information. That's additional workup. So ideally, a note would look like this, or at least have this type of information in it. This is your assessment and plan. So maybe you're following this patient with two problems, two regions that are symptomatic, and you state neck pain, stiffness, you diagnose somatic dysfunction, cervical region, still present. Well, that indicates it's really not stable. And your decision, OMT, to reduce pain and improve function. The next problem or region, sciatica right side, document somatic dysfunction lumbar region, it's not resolving, OMT to reduce pain. So again, like I said, this helps to support that decision for OMT following evaluation, and it rules out the fact that this was not predetermined. You needed to do the evaluation. So again, list each problem addressed or treated individually and document the status of the plan and the plan. Now remember, diagnoses listed in the assessment and plan but not otherwise supported with a status or a treatment plan are not going to be considered toward that level of service. And in fact, you don't want to choose an ICD-10 code from the problem list if not addressed in the visit. So this is a problematic note. Okay, we don't even have an assessment documented at all. And then there's just this list of conditions here, having no idea if one or a couple or any of them were pertinent to the visit. I mean, without an assessment and plan documented at all, this rules out the E&M right there. I believe there was a procedure following this. So, but you know, some of these conditions such as CLL, hyperlipidemia, are any of these even pertinent? I mean, if this is not affecting your decision to do a procedure, definitely should not be picking ICD-10 codes for these conditions. Now, the second medical decision-making table is your data table. So it could be just reviewing or ordering clinical labs or any kind of imaging studies, discussions with other MDs, etc. There's a lot of pieces to it, and it looks something like this. Again, it's a point system, and you do get additional points toward the complexity of the E&M service based on that. And then if you need supporting documentation, this would be good information to have within your EMR, where maybe you could have some of these key phrases already in there that you could call into the note and then just fill in the blanks. And that would help support some of that data table information. And then the third medical decision-making table is the overall table of risk, where, again, it has examples of either it's the presenting problem or there's some diagnostic procedures listed or possible management options. So the highest level of risk in any one category determines the overall risk. Documenting any comorbidities is always a good idea if they're affecting your management of the patient. So, and this goes on for 2 slides, the table of risk, but again, like I said, these are just examples. Typically, you're not going to have a patient coming into your specialty with something really minimal that you really don't need to do much about. They're probably not going to come to you unless they really do need some sort of treatment. So most of the time, at least low complexity will be supported. It could be the acute uncomplicated injury. Your minor surgical procedure and your OMTs fall into that, but the patient doesn't have any risk factors, no comorbidities that you were worried about. Typically that falls into low complexity. That's your 99213. For your moderate, which helps support a 99214, there's your minor surgical procedure with identified risk factors. So again, if the patient does have any comorbidities that you feel could affect or does affect your prescription management or your treatment options, and you document that, that will help support then that it could be a 99214 if other key components are supported as well. Or your one or more chronic illness with mild exacerbation. And then, of course, the high complexity is just documentation of the severity of the problem. But let's just quickly go over the three tables with an example. So supposing you're following a patient for low shoulder pain, that's stable, but they have a new symptom of low back pain. So we see on the first table that 1 point would be given for that one stable problem, but an additional 4 points for the new problem with additional workup for a total of 5. So 5 or more points, that's one step toward high complexity, but that's only one of these tables. So let's look at the data table. Well, maybe you've ordered some tests for 1 point. Maybe you went into the PACS system to review an image or tracing. And if you document your brief interpretation that you did that, that's worth 2 points. So a total of 3 on this is one step toward moderate complexity. So now we have one table supporting high, one that supports moderate. Well, the deciding factor is going to be this overall huge table of risk. But typically, a new problem, such as low back pain, is going to be considered an undiagnosed new problem, or if there's any prescription management, it's either going to fall to low or moderate, depending on what's been done or documented. But just keeping in mind, again, 2 out of the 3 have to meet the criteria. So even though one fell into high complexity, you're not going to pick a high-level code based on that. It's going to fall more into at least moderate. That would be a 99214. But let's just look at 2 examples of what does a typical 99213 look like versus what is a 99214. So your 99213, and I'm starting with medical decision making, kind of working backwards on this. So your assessment and plan for this patient, they have this symptomatic problem still going on. Okay, the sciatica on the right side, so it's not resolving, that's been stated, and you've decided you needed to do the OMT. Well, one problem that's not considered stable or not resolving is your typical example of a 99213. But then you want to make sure that either your history or your exam, one or the other, is supporting at least expanded problem focus. And that's not a lot of information that you need there. But you would need at least, of course, your chief complaint. Expanded problem focus history only requires 1 to 3 HPI elements and 1 review of systems. That's easy to meet. And the exam being expanded problem focused, at least, you only need to document 2 body areas or organ systems. So again, the medical decision-making piece for this problem, well, you get 2 points for one problem that's not resolving. That's low complexity. Now, on the table of risk, that actually falls into moderate because one problem with mild exacerbation gives you moderate. So now that these 2 tables are kind of conflicting each other, but remember, you need to support 2 tables. The criteria has to be met for 2 of them. And so if one of them is moderate and one's low, it's going to default to low anyway. But this is a good example of the 99213. Whereas your 99214, again, we're starting with medical decision making. We've got these 2 problems that they're not really stable or they're not really resolving. This patient is still symptomatic, not resolving. Got a total of 4 points, 2 points per problem that is not resolving is 4 points on that first table. That's one step toward high, but reasonably speaking on the table of risk, it falls into moderate very reasonably. And so that's a good example of a 99214, but remember then either your history or your exam, one or the other, have to at least meet detailed to support that 99214. Your typical 99212 is just the patient has one stable problem that's improving. And then I have these templates within here. These are the criteria for your new patient visit. So anywhere from 99201 to 205. Noting that these typical or average times are attached to these. don't worry about these times if you're picking your level of service based on the key components of history exam and medical decision making. So for example, if you have met the criteria for 99204 for a new patient, but then you realize you only spent 30 minutes on it, not 45, that's okay. Don't worry about the times. These were established 20 years ago or so. Who knows if they're really even accurate anymore. And they're just averaged times. So keep in mind, for example, in 99214, CC is a chief complaint. Of course, it's required for all the levels, but you need at least 4 HPI, 4 out of the 8. Remember, you need your 10 or more reviewed systems and the past, family, and social history, all 3. Your exam would have to be comprehensive, 8 organ systems, and medical decision-making moderate. So new patient visits, you've got to meet the criteria for all 3 key components. When you get to your established patient visits, you only need to meet 2 out of the 3 key components. I do recommend that you always use medical decision-making as one of the key components, because that really helps to support the medical necessity, the complexity of the service. I know with a lot of E&Ms, it seems as though with the EMRs now in place, sometimes it's kind of easy to document a more comprehensive history or exam because of the templates that are out there. I've seen some templates that are easily pre-populated, or it's easy to copy, paste, and carry forward. And so the medical decision-making piece kind of levels the playing field, so to speak, and makes it more reasonable as your level of service. So for example, a 99213 only requires medical decision-making of low complexity. So you just want to make sure either your exam is expanded problem focused or your history is, which only needs to meet these criteria. So one or the other. A level 4, which has moderate medical decision-making, make sure either your exam is detailed or you've met the history components for detailed, which would be these. Let's talk about the procedure note. Because OMT is considered a procedure, this requires a separate procedure note. And it should detail the regions manipulated, the techniques utilized, description of how the patient tolerated the treatment. I would make sure and separate the OMT procedure from the exam. So in this one, it's kind of intermixed. It's kind of difficult to kind of sort out what was really done here. There's exam elements, there is procedures. It makes it a little more difficult. Really, a separate procedure note, such as this, is recommended. Okay, so we've got the patient's consent documented, patient being positioned, this is your pre-service work. And then you do the procedure, the regions, etc., the treatments that were done, and then the post-service work, patient tolerating the procedure well, etc. There are times when you might be able to pick your E&M service based on counseling and coordination of care instead of worrying about those 3 key components. But more than half of the visit would have to be spent counseling and or coordinating care, and it would have to be stated that way. So let's look at what you would need to document. Because the E&M guidelines do have a specific provision to allow physicians to use those typical times associated with those codes as the controlling factor in determining the level of service when counseling or coordination of care is more than 50% of the encounter. So what you have to do then is spend the entire allotted time face-to-face with the patient, and more than half of that time is spent for that counseling, for example. So you're going to have to record all of this information, and this is what it would look like. So you would put total face-to-face time. So if it happened to be 40 minutes, you would document that. More than 50% spent counseling on treatment options. You could list what they were, relating to their diagnosis of, this would actually support a 99215 because it has a typical time of 40 minutes. And then, of course, just a review of your OMT procedures, and they're based, of course, on the body regions involved, from 1 to 2 all the way up to 9 to 10. And then, of course, the body regions referred to, and everywhere from the head, cervical, thoracic, etc. Keeping in mind that the lower extremities is one region, and the upper extremities is considered one region. So that's what this kind of goes into, is that a given treatment may require manipulation or separate techniques that are performed in several body regions, but you just have to be careful to sort it out correctly so that you're not double dipping, so to speak. So again, you want to make sure that you document based on the number of body regions involved that were treated, and document the body regions. Be very clear about that. I did see a couple notes where instead of describing the body regions, ICD-10 codes were inserted in there instead. I would say don't do that. A written diagnostic statement should be documented, and the appropriate region should be documented. So, and of course, this is an example note. So we've got the pre-service work documented. This is separate from the E&M service. And then, of course, the inter-service work, which is the procedure itself, and then the post-service work as examples. A little bit about ICD-10, making sure that you're as specific as possible, particularly when it comes to laterality. You know, make sure that you document right side versus left, or if it's bilateral. The insurance companies are taking issue with the fact that sometimes they get ICD-10 codes and it's an unspecified as to laterality. So if you're documenting right versus left or bilateral, then you've got to choose the correct ICD-10 code that goes along with it. And then, of course, any anatomic details. The important thing is, do not select codes from the problem list if not addressed in that visit. Only link the ICD-10 codes that are relevant to the visit. And of course, these are your typical OMT diagnosis codes that you would be using. And lastly, just a reminder, as I stated a little bit earlier, about clone notes and making sure, you know, a lot of the templates could easily look very similar from one particular patient, note to note. And some of the insurance contractors are picking one patient, asking for several notes, and they're looking for some sort of variation. It would be expected that not the exact same information would be present on every single case from visit to visit. So make sure any copying or pasting that you do, that you update any pertinent information. That's the important part. And that's everything I have, and I want to thank everyone for listening. Thank you.
Thank you very much, Susan. A great presentation with a lot of important information. Any questions that you may have? Yeah, absolutely. Any questions that you may have after viewing this presentation can be directed to physicianservices@osteopathic.org. We will be happy to respond to those, and if it is something that needs to be addressed by Susan, we will refer it to her. Thank you all for joining us, and I hope you enjoyed today's presentation.